Good afternoon, everyone. I am so glad that you're able to join us today for the next edition of our disease education webinar series. Today, we will be having our Ask a Doc session that we try to do annually. And I have some great colleagues with me today that I'm going to introduce to you in a moment if you don't know them. With me today is our Chief Medical Officer at the Foundation, Dr. Joseph Lasky, who's at Tulane Medical Center. We have Dr. Kevin Flaherty, who you guys have heard from not that long ago, I believe, has been on with us, who is our steering committee chairman at the Care Center Network for the Patient Registry. He is at the University of Michigan in Ann Arbor. And I am Amy Case. I am a Senior Medical Advisor for Education Awareness, and I am based at Piedmont Healthcare in Atlanta. It's great to have you all with us and to be talking today. I just want to go ahead and say, we say this at every one of our webinars, but I want to remind everybody that this is informational and educational, and we are not substituting actual direct medical advice. So any personal medical questions that you might have, we are not going to be able to answer today, and we'll refer you to your physician or healthcare provider with any specific medical questions about yourself. Now, we are going to have some question and answer today, so I'll be fielding questions in my best Terry Gross impression of Dr. Lasky and Dr. Flaherty. And if you guys are ready, we will get started. What do you think, Joe, Kevin? We're good?
We're good.
All right. All right, here we go. So we're going to go through several questions that were submitted with registration. If you have additional questions, there is a question box on your control panel to the right of your screen. Just pop that down and you can type in questions there. We will get to as many of those as we can. We generally have a lot of questions, but we will try to answer as many as we can. We will follow up with you after the webinar if we're not able to get to your specific question. So first up, and I will direct this question first at Dr. Lasky. Is there a connection between gastroesophageal reflux disease, that's what GERD means for those who don't know, and pulmonary fibrosis? And I will emphasize, not necessarily, so this is listed under causes, but I would say a connection or relationship or any association between those two things, maybe short of cause. What do you think?
Right, I'm glad you pointed that out, Amy. I think there is an association. The data shows that it's more frequent to have GERD in patients with pulmonary fibrosis. I'm not sold on, though, that GERD causes pulmonary fibrosis. I would say, though, it's probably not good to have pulmonary fibrosis and to be aspirating on top of it. So it doesn't mean you should ignore the fact that you've got GERD and that it might require some form of treatment if you're symptomatic.
Absolutely.
I would agree, although it is interesting, we don't particularly know what causes idiopathic pulmonary fibrosis and often think of it as a wound healing, meaning that there's some injuries. And so although we don't know if it's causal, there certainly are hypotheses around that reflux, could be one of those injuries that could contribute in some form to pulmonary fibrosis. And there was a very interesting small phase 2 trial published a number of years ago called the RAP IPF study, where they took patients with idiopathic pulmonary fibrosis, actually did 24-hour pH monitoring through their esophagus to prove that they had reflux, and then they were randomized to either medical therapy for their reflux or getting surgical therapy to really definitively stop all the reflux. And although the study was negative, a lot of the secondary endpoints suggested that a more definitive approach to the reflux might be of benefit. So again, not recommending reflux intervention to treat the pulmonary fibrosis, but as you said, Joe, they're probably not good in combination. And so if you have reflux, I think it's worth being treated for it.
Right, the guidelines just came out again with and they asked the specific questions, should you have surgical? Well, here it is right here.
Please, I was going to ask this question. Asking because
you've read your mind.
Because of the recent guideline update. So I think this is an interesting conversation to have. Please go ahead.
Right. So for Kevin, you probably enrolled in that trial. I was on the data safety monitoring board for that trial. So your worst nightmare. So in any event, that they came out with the not. They're not recommending it. Although I think that more information is needed, more research, more studies, and at some point, when these guidelines come out, it's a committee and they're from several different countries. And if you drill down into them, you could see that there are some people in the committee that were pro and some that were against. So this is an unsettled question.
Yeah, and I think how they approached this question was specifically for the treatment of the respiratory condition, but definitely we're in favor that yes, for treatment of GERD in and of itself, then it could be a benefit. So it's trying to tease those apart, which is how you started this conversation, Amy, with the causal relationship, which is really hard always to avoid getting confused and pulled into association, which, as Joe said, there's a strong association between people having pulmonary fibrosis and research and making the leap to causation, which we don't have that leap to make.
Great comments. Yeah, I think it was really helpful, as they worded these recommendations, that for people with, that are treating reflux, symptomatic reflux, documented reflux, that they didn't say don't treat that, but for specific for the treatment of the pulmonary fibrosis and the respiratory outcomes, that would not be the purpose of using anti-acid or anti-reflux therapies. So I think you're right. It kind of teases out a little bit and helps us in practice kind of know why we're doing what we're doing when we do it. Great discussion. Okay, we're going to jump to the next topic. This is about symptoms. This is a great submitted question. It's something that we certainly struggle with in the clinic. Actually, one of my colleagues called me about a tough cough situation with one of their pulmonary fibrosis patients just earlier today. So the question is submitted was, are there any effective treatments for relief from the chronic cough? And so I'll ask Kevin if you want to start with this, Dr. Flaherty. And I just thought maybe having a little bit of discussion about why people with pulmonary fibrosis cough in the first place would be helpful to then spring into that discussion.
Yeah, I don't think we completely understand the mechanism of cough and pulmonary fibrosis, probably because of the scarring and the traction and the forces that are within the lung probably have something to do with that. There's interesting studies where, if you put something that vibrates the back of a person, you can, in a normal person, get that up high enough that it triggers a cough. If you do that in somebody with pulmonary fibrosis, it takes much less frequency. So there's more sensitivity, to the cough. In terms of treatment for it, I wish we had a good treatment. This is clearly an area of unmet need. Cough can be multifactorial. Reflux, which we just talked about, can cause cough. Sinus and upper airway congestion can cause cough. So one thing that we try to do is to try to see are there components of the cough that are treatable, and maybe we can improve some of it. We often try cough suppressants as well, but my experience, and I'm curious your thoughts, Joe and Amy, is just that most of the time they really don't have a significant impact.
Joe, so your experience with and thoughts on this, I agree with Kevin. I think it is definitely some of the same inputs that cause anybody else to cough. It seems like it's at a much lower threshold, and then once started, doesn't stop. And so that's, I think, one of the troubling things that we deal with. How about your experience, Joe?
My experience is the same as yours. I am, however, excited, with some recent data that's coming out. So, this has not, it's been ignored for a long time, and now it's not. So there was a trial with an inhaled cromolyn that didn't meet the endpoints that was needed, but a recent trial that just came out with a medication to suppress cough, which is, like a narcotic, but it doesn't have addicting properties to it. It doesn't require us. It's not a scheduled medication, for the FDA, And the preliminary data was really good for that. And can I put a plug in that I think they're going to be doing a trial with this in the first quarter of 2023. So I would encourage you, if you do have a bad cough, to go to the PFF website finder for trials, find that trial and get yourself enrolled.
Yeah, absolutely. Great plug. I'm excited to see that there are sponsors and people working more on this problem. It's such a quality of life issue for our patients, and getting some better solutions that might give them some relief is really, as you said, an unmet need. So it's good and exciting to see work in this space. So let me see. Let me go. Yeah. Okay, so we're going to switch a little bit to disease management. These are the questions that we received ahead of our webinar, but I also have another one if we want to comment on as well when we're talking about management, progression, and so on. First of all, before we even talk about that, how do you define severity of disease? Like, do I have a stage of pulmonary fibrosis, or is it mild or moderate or severe? And how do you decide that in your clinical practice? Joe, I'm going to let you take this first, and then we can kind of dive through these other questions as well. But this was a live question. I thought it was very relevant to this part of the discussion.
Well, there is a formal scoring system called the GAP system that looks at radiologic, clinical, and symptoms and pulmonary functions, et cetera, where they can be staged as to, 1, 2, or 3 in severity in that regard. I seldom score someone like that in the clinic. One can certainly score someone by their function, their diffusing capacity, how well gases cross into the bloodstream, and how much air they're able to get in and blow out of their lungs, the forced vital capacity. That's one way. And another way is looking at the CAT scan and seeing how much involvement of scarring is on the CAT scan. But those usually correlate pretty well with how the patient's feeling, but sometimes not. And so we can't dismiss the fact that really the most important thing as to how severe something is or how bad it is how does the patient feel?
Yeah, I couldn't agree more. All those things are important in trying to help understand the severity. And at the end of the day, I tend to be, I think kind of what you're saying, Joe, is looking at how the person is doing. Someone may have pulmonary fibrosis and almost no symptoms, very early disease, and I call that mild. Others may have definite symptoms, but yet don't need oxygen. So maybe that's more the moderate stage. And then once you get to requiring supplemental oxygen, then you're certainly more advanced or severe. So not a hard, fast number system per se, but more just combining symptoms, which, as you said, usually correlate with the amount of fibrosis on a CT scan or how abnormal the pulmonary function studies may be.
Yeah, that's great. That's actually a really good description of the symptoms and oxygen need, that kind of holistic approach to that. It is certainly more general than something that's like a GAP score that you mentioned, Joe, but I do think it's very meaningful, and it brings back the patient's experience into into what we're talking about in the clinic. So I'll move forward since there's a bit to discuss here. Our next question, is there anything that can be done to slow disease progression? And connected to that is, at what point in the disease journey are medications such as pirfenidone and nintedanib prescribed? So I will put up this. I thought the three of us have seen this many times, this graph, and I thought this might prompt some of that progression discussion. Kevin, I'll let you go next. Sorry.
We're like good students waiting for the teacher to call on us.
Yes.
So yes, there are 2 medications that are approved that do just that. They slow the progression of scar tissue. Pirfenidone and nintedanib were both approved actually on the same day in October of 2014. And you have the data right there in front of us, so thank you for that. So if you look at the left-hand curves with nintedanib, those are showing declines in forced vital capacity over the year of the study. And what you'll notice, first of all, is the nintedanib group is the blue on the top, and the placebo is the curve below that. That's more of a white or gray color. They both got worse, so neither of these drugs stopped, or neither made that slope go up and improve lung function. But either the nintedanib on the left or the pirfenidone on the right, you could see that the decline in lung function was about 50% slower with either drug when it was compared to placebo. So these drugs have been around for a while, and they do seem to bear out in real world experience in terms of slowing down the progression of disease.
Fantastic. Joe, do you want to make some comments on kind of I always ask, like, is this, I get asked frequently, is this normal? Is this typical? And I struggle to answer kind of what is normal. I think progression can be highly variable in patients with pulmonary fibrosis. Maybe you could talk about that a little bit and what this graph means.
It is highly variable, and there's a lot of research going on right now to be able to do a blood sample or some other test and predict, whether someone's going to get worse more quickly or at a slower slope, or can they predict that you've got this one with a little star where they have a big step down. That's something we'll talk about later, an acute exacerbation. Along these lines, I wish we had something ready right now that we could, predict for an individual patient which of these slopes that they're going to be on, or whether their slope this 6 months is going to be different than the slope of decline over the next 6 months. Is this the time to talk about the when to start the medication, or is that?
Yeah, I think that's a really good segue.
Well, I have a bias, and so let's look at a different lung disease, emphysema in a smoker, and I may have a smoker that's got a little bit of emphysema, and I'm not going to say, well, you have a little emphysema, don't stop smoking cigarettes now. You're not symptomatic. It's too late by the time someone's symptomatic. So for me, the earlier we can treat a patient, the earlier we can change that slope, and we have a longer period of time to preserve lung function in somebody. So the sooner the better, as far as I'm concerned.
Absolutely.
I would agree with that. You could use another lung disease as an example, and we know that without therapy, the prognosis of idiopathic pulmonary fibrosis is actually worse than many cancers. And it's hard to imagine going into someone's office and saying, yeah, you've got cancer, but we're not going to treat it yet. We're just going to wait and see how fast it grows. The caveat on the other side is both these medicines, unfortunately, do have common side effects. So nintedanib, about 60% of people will have diarrhea. Now, some will have none at all. A small percentage will be really severe and the medicine's just not tolerated. Most of the time, it's more manageable. And similar with pirfenidone, about a third of people may have some decreased appetite or nausea and have to wear sunscreen so they don't get a skin rash. So they're not perfect medicines. And at some point, you have to look at, the overall picture of, all the other medicines somebody might be on, or their stage of disease, as we talked about, and really kind of weigh the whole quality of life, quantity of life types of discussions, which is what I usually do with my patients. I certainly, to have that really fairly long discussion, about starting antifibrotics as soon as we know what the diagnosis is, and try to help make an informed decision.
Yeah, that's a really good point. I think that a shared decision-making model is important for something like this, where, as you described, many people experience side effects, and I think it's important when getting into something like taking an antifibrotic medicine for disease like pulmonary fibrosis, that people understand what they're getting into, so that should those things come up, should they experience side effects and have trouble tolerating, they understand what to expect, then what to do, who to call, and have the highest likelihood of being able to stay on that therapy with support or modifications or something along those lines. I think if you don't have that open conversation, I think you run the risk of patients not remembering or knowing why they're taking, what to expect. They're surprised by something and they go, okay, well, I've just experienced a week's worth of loose stools. I don't want to take this anymore. I'm done. Whereas I think if you're more open, transparent, two-way conversation about risks and benefits, then that's less likely to happen. And I agree with Joe, have that conversation early. Don't wait and decide, later that, well, now we'll talk about it and figure out if this is the right thing to do. Figure that out on the early side and again, shared decision-making, open conversations about them. I have an interesting question. I'm going to reframe the question just a little bit from our live audience that fits here. And I may ask Joe to start on the answer, and then Kevin, please, after. Are there any known factors that will predict response or success with nintedanib or pirfenidone? Patient-related factors or disease-related factors, for example. Joel?
I am drawing a big blank right now on that. Again, there's a number of papers that are out there that are suggested, but they haven't been replicated, or they're not ready for prime time or commonly used in a doctor's office. Certainly that's our goal, and there's a lot of work being done to try to get there. I might be forgetting or not thinking of something though, Amy or Kevin?
Yeah, no, I'm not not aware of anything, and that really, comes back to some of the difficulty in following after starting one of these medications, because, as Amy showed on the prior slide, they slow progression but don't stop it. So people will still have a decline in lung function, and you frequently ask, well, how do I know if the medicine's working? And it's not like a diabetes medicine where you can say, well, look, check your blood sugar, it's normal now, or blood pressure, look, your blood pressure, So you have to have some trust that even if things are getting worse, that the medicine is likely working, and things might be getting worse more quickly without it. My approach to changing therapy is, I certainly will offer a change in therapy if people seem to be progressing, but if they're actually tolerating without significant side effects, I really don't recommend a change. However, if someone seems to be struggling with side effects on one of the agents, really common, like I'm just nauseated all the time, or I'm really having more stools than I, are they interfering with my life, then that for me, that makes it easier to say, well, let's see, maybe you'll tolerate the other medicine a little bit better. We don't have head-to-head comparisons of these medicines, but each of them compared against placebo and just my clinical experiences, I think they both work. I don't feel that one is better than the other. At least that's my personal opinion.
Yeah, I agree with everything that both of you said. I think that was a little bit of the question there is intent. I asked it just to have you both say that we don't know of any factors that would predict success with one or the other. And a physician prescribing those medicines after a conversation about risks and benefits for each, meaning side effects and benefit. And then also just reviewing other illnesses and other medications that might have any interactions with one or the other. Otherwise there isn't a hard or fast rule about, are there factors that would predict success or failure or otherwise. Now, I think I agree. This is such a good topic. We would like to know, because you'd like to give a person the thing that's better for them, since they do have different mechanisms of action, but we just don't have that science in front of us yet.
Yeah, and I think the other thing, and I think we'll kind of get to some of this in terms of questions that may be coming up, but we think a lot about pharmacologic therapy, but I think it's important to treat everything that's going on, so oxygen, if you need oxygen, pulmonary rehab to stay in shape. We know that the more other illnesses you have, the worse you're going to do. So treating that sleep apnea, treating whatever is there, and really trying to treat the whole person with pulmonary fibrosis. And it is a person with pulmonary fibrosis, so treating that entire person, I think, can help apart from just starting an antifibrotic medicine.
That's such a great point. I think it's really important to remember that it's not just lungs that we're dealing with, but a whole human, and remembering those other things. We are going to get to some of that in a moment, but I have a couple of questions about acute exacerbations. And we did have a webinar, I think it was a few sessions ago, maybe last year, about emergencies and acute exacerbations, if anybody's interested in going back to view that. It is on our YouTube site. But first, I'd like to ask, I'll go, Kevin, since I went to Joe first last time, a couple of questions. We'll start with, what is an exacerbation of pulmonary fibrosis? Secondly, we'll talk about what should somebody who's giving care or taking care of a person with pulmonary fibrosis do if that person is experiencing symptoms of an acute exacerbation. We're concerned about that. And then I allowed one COVID question in this session, and that is that we know well that COVID-19 can cause or exacerbate pulmonary fibrosis in certain situations. So it is a risk for our community, but can the vaccines do this? And then the weight of how concerned should we be about that is sort of a secondary question. But let's start with what is an acute exacerbation. And Kevin, I'll give you this to talk about. This is a little technical, but I thought this would be helpful.
Yeah, darn it, I missed the webinar. Now I wish I would have gone back and looked at it ahead of time so I'd know how to answer this. So what an exacerbation is, I think we're still trying to figure out. I mean, we define it as over a fairly short period of time, usually a month or less, where someone will have worsening, symptoms, worsening oxygenation. Usually on the CT scan, there's more haziness that we sometimes call ground glass and think that might be inflammation, although sometimes it's microfibrosis. We tend to think of these flare-ups as, either idiopathic, like I can't explain it, or maybe it's from something like I choked on something and maybe something got down in my lung. We call that aspiration, or I had a recent infection and seemed to get better, but now this is happening. So, it's kind of a triggered type of an exacerbation. So I'll stop there and see if Joe can maybe clarify, his thoughts or defining exacerbations, because they are hard to get our heads around, both clinically and certainly, we try to follow these in our clinical research studies as outcome measures, and they're hard to define there as well.
Right, Kevin, I think you elegantly explained that. I don't think I have that much to add to that first part of the question.
All right, well, Joe, I'm going to ask you then the second part of the question. Somebody is in your clinic and you have a patient and a caregiver, and the caregiver says, look, I understand that an acute exacerbation might happen. I kind of know that this is serious. What should I do and what should I be looking for if I'm worried about this?
So going back to something Kevin said earlier, a lot of people with pulmonary fibrosis are in their 60s and 70s, and they have other diseases as well, such as coronary artery disease or this sort of thing. So, I actually like to get that patient in and get worked up right away to look for these other things that could be masquerading for this unexplained worsening, such as perhaps a blood clot, thromboembolism from the leg, or their coronary arteries are getting pretty narrowed and the heart is starting to fail. And if we got them to the cardiologist, they could dilate those blood vessels and put a stent in. These types of things, or find out if there's some sort of an infection, either a typical community-acquired pneumonia, or perhaps they've developed a secondary infection to some sort of atypical organism, such as a cousin to tuberculosis, not a contagious tuberculosis, but a mycobacterium or something along these lines. So again, we're looking for other treatable causes. We don't want to assume that this increased shortness of breath is due to something that's changed in the lung. What Kevin said about getting that CAT scan done right away, though, helps us point to the lung and say, well, yeah, we think it's going on in the lung.
That's great. Those are great points. I think coming up through this is just to remember that an acute exacerbation is a serious and significant event for a person with pulmonary fibrosis. So if there is concern, have a low threshold to ask for help, be seen by a medical provider, call your doctor. If that's not accessible, urgent care, emergency room, that kind of thing. To really this is not something we sit on if it's a concern, and that needs to be urgently evaluated because, as Kevin said, this is, significant, serious, and can be life-threatening for patients with pulmonary fibrosis. So the last, and I don't have a picture for this, but the last question about COVID-19 vaccines and any risk for acute exacerbations. I think that stems from a recent publication out of Italy. It was a case series, not a lot of patients in it, but demonstrating a temporal link between some hospitalizations for pulmonary fibrosis acute exacerbations and the timing of their vaccines. And I will just ask, maybe I'll go back to Joe on this one about, is that possible? Does it happen? And how concerned should we be about that? And I'm going to ask this in a way that there's no other way to answer it, but should people be worried about getting vaccinated against COVID-19 because of any risk of acute exacerbation?
So, based on what's out there in the literature, and you mentioned, one manuscript, I'm not convinced that the vaccine causes an acute exacerbation in people, even though there is that one paper. And hands down, the answer is get the vaccine. Your chance of having a bad outcome from a bad COVID infection because you didn't get the vaccine is orders of magnitude higher than this theoretical possibility. Maybe could be, probably not, getting an acute exacerbation from getting the vaccine. That's my bias.
Kevin, any comments on that?
I could not agree more. Absolutely.
Yeah. And quickly for both of you, are you recommending booster shots and second booster shots for your pulmonary fibrosis patients when appropriate?
Yes, I got mine.
I'm old. I got mine.
Yep.
I too have been boosted. I won't say how many times. So I think we have a unanimous agreement on the theoretical risk of an association with acute exacerbations is far lower than the havoc that an actual COVID-19 viral infection can cause in an unvaccinated individual. And that we are recommending pretty universally to our patients in our own clinics and to apparently ourselves that if you are a candidate for a booster shot and potentially second booster shot when the time comes, that we are recommending that as well. And that is the last pre-submitted question I have about COVID-19. And I actually forgot to show this. So this is just an example of a CAT scan, a CT scan on the left at baseline showing some lung fibrosis in the periphery, the heart in the middle. If anybody's not seen a CAT scan before, that is supposed to be there. But then how much more kind of white and gray there is on the right-hand side at the time of an acute exacerbation. It's just a demonstration of that kind of widespread damage to the lung that can happen in those events. And I'm not a radiologist, so I wave my hands a lot when I look at CAT scans. All right. Kevin, I'm going to direct this one to you because you started talking about kind of comprehensive management of pulmonary fibrosis patient. And we did have questions about pulmonary rehabilitation. And we all agree, I think this is an important component of management of pulmonary fibrosis. So our questions here are what can a person expect from a pulmonary rehabilitation program, and what are the benefits of pulmonary rehabilitation? So I'll let you talk about that a bit, Kevin.
Yeah, so, and I like the slide that you put in there, because I think at the baseline level, we often think of pulmonary rehabilitation as an exercise program, and that is a really good core of it. You know, it's nice having a program where you can be coached. A lot of times it's hard to exercise when you have symptoms of shortness of breath, because you're maybe worried, am I hurting myself? But if you have someone there that can be monitoring your oxygen, or saying, yeah, it's okay to push yourself, I think we all get motivated a little bit more. It's like my treadmill at home that is wonderful for hanging clothes on. That's not what it was designed for. The other aspects of pulmonary rehab are really, you know, there's a lot of education that goes into it. You know, so there's more than just the exercise. So it really is, you know, a great program. There are clear data out there in fibrotic lung disease and other lung disease that following a course of pulmonary rehab, your disease isn't going to change. It's not going. You can't exercise away your pulmonary fibrosis, but you can get your body in better shape to deal with the lungs that you have. And so with any given activity, your shortness of breath will likely be less, and you'll actually be able to do more activity. You'll be able to walk further and do more following a pulmonary rehabilitation program. So I'm a huge advocate of exercise and pulmonary rehab.
Excellent. Joe, can I get you to just say, like, if you were going to describe to, let's say a Martian came to Earth and said, Dr. Lasky, what is pulmonary rehabilitation? What would you say, like, what does that look like to go to sign up for? What is that person going to do when they get there, stuff like that?
Right. So, you know, I can give you, you know, our program that what they'll do is they'll meet a respiratory therapist, you know, that'll talk to them about using medications and you know, breathing techniques and this sort of thing. A nurse, you know, which will help them with their questions about their medications and their overall general health, et cetera. And also a physical therapist, you know, who will, you know, be coaching them on the amount of activity that they're doing, or, you know, oh, I've got a bad knee, I can't do this. Well, maybe you could do this instead. So we have several different pieces of equipment. And so there's a whole team in there that's working. And even though we talked about all those other things, as Kevin mentioned, if you're really not careful when you go there, you're going to learn a lot.
Absolutely. I think that's a good point that you have about being able to, when you're in a program with the therapist there who's skilled at pulmonary rehabilitation and trained to conduct that for people. They don't just give you like a plan and say, get on the treadmill and go. They tailor that to a person's abilities and disabilities and kind of where they are with their functional status. And it's not just, I'm not just going to go to class and walk on a treadmill for an hour. I'm also going to do, you know, if I can't do the treadmill, I might do a recumbent bike. If I can't do that, I might do an arm bike. If I, that probably has a different name, but I don't know what it is. If I'm going to do an aerobic exercise, I'm also going to do some strength and conditioning exercises. So my upper and lower extremities are going to use body weight, but also some light weights and bands to get some strengthening there and conditioning of those muscles. Because as Kevin mentioned, you can't exercise away your pulmonary fibrosis, but you can become a more efficient machine. So that less gas in the tank goes further with conditioning and through the pulmonary rehab process. And I think that educational component is so important to understand how to manage your own disease and kind of be in a little bit more control of the situation. And then also learning about how to maintain those gains after the formal pulmonary rehab sessions have ended. What happens next, and where do I take this, and what do I then do? And hopefully you've learned at the end of that how to continue to make progress. So all really important points. I got a question earlier. Kevin, I'm going to ask you this because you said you can't exercise away your pulmonary fibrosis, and this goes back to use of oxygen, but you know, is there anything that is gonna change that course? We had a question submitted, I didn't drop it here, but if a person goes on oxygen and then has an increase in their oxygen needs related to disease progression, is there any thoughts that oxygen need might then go back down through pulmonary rehab or medicine or what have you? Is that something we can expect?
Yeah, usually not. You know, the medicines we have slow progression, but don't reverse it. So usually the oxygen you need, I mean, and we've all been, you know, we're dependent on oxygen since day one, right? You know, so that requirement is there. Kind of building on that or just expanding a little bit, it's really important to use the oxygen so that you can exercise and do more. And that's what I was kind of alluding to, is we're all dependent on oxygen. So I think sometimes there's a fear, which is understandable, that, well, once I start using that oxygen, I'll become dependent on it. Well, we're all dependent on it. And if your oxygen levels are low, that's going to put a lot of strain on your heart. So in my mind, it's much better to use oxygen so you can exercise and stay fit. That's going to be your best defense against whatever, is having a fit body to fight whatever comes down the road at you, versus becoming more sedentary. Well, I'm just not going to do as much, because if I don't do as much, then I don't need to use that oxygen. So it's probably not going to go away in terms of having to use it, but along those lines, I think it's really important to use so you can maintain your fitness and stay as active as possible.
Those are great comments. Thank you. I tossed a little curveball in there. All right, and that's actually going to go back to Kevin. Lung transplant. So if you could, for us, describe the transplant evaluation process. Talk a little bit about when we should start that process if we're interested in pursuing it. And then talk a little bit about, as a transplant physician, what factors do we consider during the evaluation process?
Yeah, so it really is a process. You know, patients that meet criteria for lung transplant, it's really it's our last resort in terms of you know, a life-saving procedure when our medications have slowed the progression, but it's still progressed, and you know, without a transplant, the disease will be, you know, will result in more early mortality. The process, as I describe it to my patients, is we're really trying to take a holistic approach at you to see, are there things under the surface that would prevent you from having the best outcome possible? So that starts, you know, makes sense, but with insurance, will this be covered so you can pay for medications and procedures after transplant? Once it's authorized to go through the evaluation process, there's a lot of medical testing, heart catheterizations, make sure all of your cancer screening is up to date. Do you have a cavity that would become infected because of the immunosuppression? So dental clearance. It's really looking very holistically medically to see, is there an unrecognized medical condition? Think of it like an iceberg that's sitting under the surface, and if you run into that, it's going to cause a huge catastrophe. So sometimes we find things under the surface that prevent us going forward, or more commonly, we can address it, and then it's no longer a problem going into the transplant. We also look a lot at the social situation. This is a major operation, and it takes a lot of family, friends support, caregiver support to get through this process. And so we have a lot of you know, social evaluation to say, what's your support look like? Some of our most unfortunate outcomes is when that wasn't been up to snuff when we thought it was, and the patients didn't have the support they needed. Education, right? Like, what is a transplant and what is it? So we have our candidates go to at least one support group meeting where they can talk to people that are either on the list or have already had a transplant, so they can talk to their peers and say, hey, what am I getting myself into? What does this look like? So it's really a very holistic approach to making sure that we think you're optimized to have the best outcome, and that you're comfortable knowing what you're getting into and know what to expect. So we go through this at our center. We go through this whole evaluation process, and then we sit down as a committee of surgeons and doctors and nurses and social workers, a whole committee, and say, yep, we think it's a candidate. And then I go back to my patient and say, okay, you're a candidate. Are you ready? You know, because when to start evaluating for a transplant is a really hard question. If you wait too long, you'll never get through the evaluation process, or you may be too sick, you know, so you don't want to wait too long, but yet you don't want to go too early, because transplants can be life-saving, but they don't last forever. And sometimes they, you know, as you say on the right of your slide here, you know, there is 1 in 10 that'll have a complication and not survive 1 year. That's, you know, rare. Most people do well, but not always. So you kind of want to find that sweet spot of when is the right time to list me, so that I'm sick enough that I'm going to benefit, but I'm well enough that I'm going to be, as soon as I get lungs in me, my body's going to go, thank you, I'm ready to go, and I can get myself out of the hospital. And so we'll have that discussion and say, are you ready to be listed? And that depends on how sick someone is and how they're progressing. But we try to evaluate people a little bit on the earlier side. Certainly once people are getting to need oxygen, I think that's probably one good marker of, yeah, if you're sick enough to need oxygen, we better look and see about, you know, getting this evaluation done. And maybe at the end of the evaluation, we say it's not right time. But then if 4 months later, 4 weeks later, 4 months later, you have that exacerbation, and now it is the time, you've already been evaluated and you can become active on the list. I'll stop there. There's a lot more on your slide here that we can talk about, but I know we're tired. I don't know how much you want to get into, or if Joe has other thoughts. I can talk more about these other things if you want, but I've said a lot. So
that's great. I think, I think those are great answers to the question. It's nice to hear from somebody who does transplant every day. Joe, I'm going to ask you, as I know you said earlier, I'm not a transplant doc, and via email, but you refer patients for transplant. You treat patients with pulmonary fibrosis all the time. What is your thinking about timing of that evaluation and referral if you've got a patient that is potentially interested in seeking a transplant?
Yes, thanks. You know, so for referral, you know, many of the same parameters that Kevin, you know, had mentioned, you know, is someone losing lung function rapidly over time? Has their diffusing capacity reached a threshold, you know, where it's maybe 40% of what we would expect it to be? Are they needing to go on oxygen now? You know, indicators, you know, those are when I refer and do it early. I do want to make sure that I draw your attention to the PFF website, which has some great videos on lung transplant and, you know, patient experiences, what to expect, what was it like. You know, these are really high quality, informative videos.
Absolutely. Yeah, that's a really good point. We've had several webinars on transplant, as well as we've had sessions at Summit, which are posted, as well as some patient videos just talking, you know, first-person experience about the transplant process, recovery, as well as those who are listed and waiting. And you can hear directly from those folks that are going through it and have been through it. And I think that's a really useful resource. And those are found easily on our website. If you can't find them, let our help center know. So I'm gonna ask, I'm gonna go back to Kevin about this first question, and also get some comments from Joe, who's of course our Chief Medical Officer and knows a lot about this stuff. But Kevin, in your role with the PFF registry, I thought you'd be a good person to talk a bit about the information collected, and then we can talk a little bit about research being done on familial pulmonary fibrosis within the registry, as well as in other venues outside the registry.
Yeah, so the registry started, you know, several years ago, and there's different types of data that are collected. There's clinical data that might be things like, what is your diagnosis? What is your level of lung function? There's imaging data. The sites where you're seeing, if you're in the registry, will upload without any of your identifying information. It's all anonymous, but your CT images. So researchers can look at the CT images of thousands of people to learn about how this disease behaves and progresses over time. Patient-reported outcomes. Those are questionnaires that assess, how are you feeling? You know, what's your cough like? What's your energy level like? What's your mood like? And then blood samples. As Joe said earlier, we're really trying to find a blood signature or something that can predict course or even predict response to therapy. So collecting blood samples that researchers can, you know, submit a research proposal and get access to those to do some research. It's a huge resource. You can imagine if you came up with an idea and said, okay, I want to study these blood samples, and I need 500, and I'm going to have to get those one at a time. You know, it's going to take you years to do that. But if you could say, wow, the registry already has collected thousands of those, and I've got a really good idea, and then you can use them all at once to try to rapidly move that science forward. You know, the way the registry is done now and has been done is sites where people are seen, enroll people. They get you to sign a consent document, and then the investigators at the site, they don't do anything different to your care. Your care is done based on whatever your doctor does, but they monitor it. They go in every 6 months and they pull out what's happened to you from the medical records. So it's very much centered at the site. One of the things that's going to be launching very soon this summer will be a version of the registry where patients, independent of the care centers, can actually enter their own data online. It's kind of a subset. Obviously, there's not a blood sample there or CTs, but you can enter information even if you're not at a center. So we're really excited to have this new version of the registry opening, and the website is up there, and you'll be able to see some information. But I'll stop there. But I think this is a huge resource and a huge, you know, thank you to all the people that have participated so far in the registry and shared their data and put their arm out and let blood be collected. And then a forward-thinking thank you to those that are going to continue or start participating when that's available.
Yeah, and before we go, thank you so much. That's super informative. Before I go to Joe about, I'm going to come up on some genetic stuff in just a second, but if anybody is interested in participating in the registry when it reopens to enrollment, you can just to reiterate, you can do that from anywhere. You do not have to go to a specific site or be seen by a specific doctor or healthcare center or one of the care center network sites. You don't have to be close to them, far away from them. It doesn't matter. You don't have to be an active pulmonary fibrosis patient. You could have had a transplant. You could be a caregiver. And still we are collecting data from all of these different parties to learn more about the whole experience of being a pulmonary fibrosis patient and what that life is like. And so, excuse me, if you're at all interested in that, please go to the website, registry.pulmonaryfibrosis.org. You can enter sign up for be one of the first people to get information and invited to come and register yourself for participation in the registry. Excuse me, I'm going to cough. And participate, like Kevin said, from anywhere, and help contribute to this. I'm actually going to skip forward really quickly and just go to that genetic question and give that to Joe. Research into familial pulmonary fibrosis, and then also a question about genetic testing. And I wanted to reflect back, and you can speak to this as well, to our genetic testing in pulmonary fibrosis position statement that was published in 2020. There's a version for healthcare providers as well as patients. And Joe, I'm going to put you on the spot here, and then we're going to flip back to the other question.
Well, I'm glad you brought up that statement that's on the website in regard to genetic testing. I think it's very well explained there, and a lot of thought and effort went into putting that together. I'm guessing, not guessing, but maybe 1 in 10 or so, maybe a little bit higher than that, has other family members who have pulmonary fibrosis, and not for all of those have we identified the specific gene that's associated with it, which is causing it. But we do know a couple of genes where there is an association, and most of these gene point mutations result in early accelerated aging, for lack of a better word, or we call that senescence, so that the lung or the cells become older a little bit before their time. if we live to the age of Methuselah, all our lungs are going to get old. But some are going to get older more quickly than others, and sometimes it's due to a point mutation. And one of the ones that we hear about is in telomeres that would keep the telomeres long. So what's a telomere? You know, to me, if I look at my shoelace and I've got that little plastic part on the end of it, the aglet, and once that little plastic piece breaks off, I can't lace up my shoes anymore. And so that, that shoe is not useful, and it kind of goes to sleep. But it's still active, and active in a bad way. A senescent cell, it's still in the body, but it's like a grumpy old man in the neighborhood. It's kind of ruining it for everybody by spewing out vitriol and this sort of thing. So a lot of these, point mutations that we all have in one form or another for various organs lead to premature aging of the lung and early senescence. And some of these are associated with things that keep those telomeres at a good length so that the cell can continue to function normally.
Thank you, Joe. This is truly a complicated area. I think where we're starting to understand a lot about that biology. And there is research going on in this area. There's definitely a lot of interest in the genetic components of pulmonary fibrosis, both within registry projects. So we are collecting those blood samples that then can be tested if there's an interested researcher that has a project. And then there are other organizations that are studying familial pulmonary fibrosis and looking at those different mutations or 4 new mutations that we don't already know about. I will say that I would refer anybody who's interested in learning more about this to our position statements and strongly considering genetic counseling and especially talking to one's doctor prior to undergoing any type of genetic testing, because there may be different things for different situations that might want to be considered. Okay, so I'm going to take this question. I will have the two of you also comment on this, but where can I find information about new clinical trials, and is there any timeline for new treatments? I'm going to point you to the same website. I've got it listed here, trials.pulmonaryfibrosis.org. So this is the Pulmonary Fibrosis Foundation's clinical trial finder. Joe mentioned this earlier. It is a fabulous resource. I highly recommend you go to it and then bookmark it and come back to it because things will change. You have the ability to go in on this site and match yourself to clinical trials that are within a distance from you and that your clinical situation would make you a candidate for. So you can type in this, you'll come up with this homepage. You can click match here in the middle. If you want to just look at studies, that's okay too, but you can click match. And so let's pretend you do that. You'll have the opportunity to answer a couple of questions about yourself and about your disease and what you're doing about it. And then you will have an opportunity to come to a page. So I put in some information here, and the trial finder found 69 clinical studies that I might be a candidate for. Now, some of these are very far away, so I could go to that location button and I could take down the radius that I'm willing to travel quite a lot. It'll show me the closest ones first, but then it'll it'll go further out, so I can narrow that by distance. I can also go to the different phases of trials. If you don't know much about that, we have some clinical trial education on our website within our trials trial section as well. So we could talk about whether it's a phase 1, 2, 3, 4 study. And the study type, is it something that will test, is it testing a new medication, a new other type of intervention like pulmonary rehab or something like that? Is it just observing, like the registry that we talked about, just watching to see and collecting data? And you can narrow by study type as well, because when it pulls up this information, it will show you all types of studies, all phases of studies. But if there's something more specific, you want to narrow that down to options, and then you will come up with a list of studies that you are potentially a good match for. And then information about them, you can get to contact information for your closest site. You can reach out and see, if you want to participate, if you truly are a candidate. This will not tell you definitively yes or no. There still is a screening process in place that has to take place at that trial site. But this is a good indicator. So if you're looking for new studies, again, bookmark this, come back, revisit, and then very soon we'll have an opportunity to put in some information and then create a profile so that you can come back to that information later and not have to re-enter your data over and over. So bookmark this. It is trials.pulmonaryfibrosis.org. Everybody go visit and investigate a little bit further. And we are actually, boy, we have had a lot of discussion. We are right on 2 o'clock Eastern, 1 o'clock Central, and all the rest for the rest of the country. So I'm going to wrap it up. I am going to tell you guys, thank you so much for being here, for all your wonderful questions. We are going to be following up with folks where we couldn't get to your questions. I had so many. You guys are really, really popping with questions today, and I really appreciate your engagement and interest. I have to thank Dr. Joe Lasky and Dr. Kevin Flaherty for joining me today. Your discussion is just invaluable, your experience and advice for our group here. I'm going to plug our upcoming next webinar at the end of June 22nd. This will be focused on palliative care, supportive care by Dr. Anna Gersten is going to join me to talk about that. This is going to be an excellent discussion. And then thank our sponsors. I will also ask you guys, when we close the webinar here, to stay for just a moment and give us a little bit of feedback. We will not get a follow-up email about this webinar, but this is your opportunity to give us feedback about our webinar today, as well as the series, and help shape the future of our disease education webinar series. Any last comments or remarks, Dr. Flaherty, and then Dr. Lasky?
No, just thanks for inviting me. This has been great, and thanks to everybody who joined and for submitting the questions. As Amy said, the questions were really, really deep and profound, and I'm sure that a lot of people wanted to hear our thoughts on those. So thank you for inviting me, and it's been a pleasure to be here.
Thank you. Dr. Lasky.
Indeed, Amy and Kevin, great always working with you. I want to make a pitch, all right? So these questions were great, and some of them we were pretty good at answering, and that's from work that's been done in the past. But some of them, maybe our answers aren't what you would want them to be at this point, that we need to do more work, we need to do more research. And in order to get there, it's going to take all of us. That means the people here in the listening audience. I really want to encourage you to enroll in the registry, because that's going to help us answer some of the questions that you've been posing today. And also go to that trial site and get enrolled in an additional clinical trial. You can be on an antifibrotic, and maybe you're losing a little bit of lung function over time, and get an additional medication added on. We're all going to be a lot smarter and a lot better about caring for patients with pulmonary fibrosis if you get engaged in these trials and with the registry. So thank you.
Absolutely. That's a great point, Joe. The reason that we have the therapies that are available for our patients today is because people in the past participated and took part in the process and enrolled in a clinical trial. And that's the reason that we do today. We will go further. We'll go further faster the more people engage and participate, and the more we can learn. So great advice, and I encourage everybody to listen to him. He's a smart guy. All right, you guys, thank you so much, and we'll see you at our next webinar. You guys have a great afternoon, and we'll see you next time. Bye.
Bye-bye.